So my plan was to give you an update about, first of all, the introduction, but what is congenital phenotype correlation? I mean, this is a concept that's quite well known for people working in the field, but perhaps for parents in particular might not be that obvious. And why do we need genital phenotype correlation? So just for sake of time, maybe I will just skip a little bit quicker on the congenital muscular dystrophy part and focus more on number 2. So first of all, what is genotype? One is phenotype. So these are two concepts that we use very often in clinics and in genetics in particular. So genotype is the variant or the change that you have in your gene or that you get from your parents. So you get two genotypes, two alleles, each from each parent. And the product of this gene is your phenotype. So for example, talking about simple things, a gene that is relevant for the color of your eye makes your eye brown or black or blue, and the same for your hair and so on. Now the same could then reflect for disease, where you have a gene that is relevant for a function of a protein that is relevant for the muscle will give you, and a change in the gene, the genotype of the gene will give you a phenotype, in this case your disease. Now, we talk about muscle conditions. We have a lot of genes, over 500 genes, a lot of proteins, and we have other genes that are probably not known yet. So we know that there are somewhere where we don't know which genes are the ones that we're looking for. And we have a lot of different phenotypes. So we have a lot of different muscle conditions. We have congenital myopathies, we have dystrophinopathies, we have neuropathies, and so on. But these are not really distinct entities. So we don't have 500 genes and 500 conditions. But what we have is actually a situation which is a bit more like this, where phenotypes are a little bit more overlapping. And very often you have this situation where, unfortunately, instead of having one disease, one gene, so one genotype, one phenotype, and in particular one specific change in your gene causing one specific phenotype, so variant A in gene A causing disease A, and the same variant B in gene B, disease B, what you have, unfortunately, is something like this, where you have multiple genes causing the same disease, and you might also have a situation where you have multiple genes causing the same disease. So it's a little bit more complicated, and unfortunately the concept of one gene, one disease in particular in the condition that we look after is really not existing. So it's not that simple to say genotype, phenotype, and this correlation is not really one-to-one. Gene A, disease A, and so on. So the term genotype-phenotype correlation is really, we're trying to associate a specific variant in a specific gene with the resulting disease expression. And why this is necessary? Because if I know which variant in which gene causes which condition, so if this was really tight, variant A, disease, gene A, disease A, then I could tell you, just looking at the gene change, which condition that person will have if you carried that variant. And that's important because if I find that out at birth or before birth, I can very clearly say, that's the diagnosis, you will have condition A. Okay, so if I have condition A, will I have a risk for my heart? Yes, you will. When it will happen? And when you're 10. Clearly, I'm just exaggerating now. And this also will tell you, so if I have this gene change and this variant, well, will I have the same phenotype in all my children if they have the same change? Each family member will have the same disease. So clearly also give you an idea about counseling. So you want to have more children. So if my child is mild, for example, will the second child also be as mild, or will that be more severe? And clearly this can also help you with clinical management because, for example, if I have a gene that causes a specific condition and causes involvement of the heart, I will monitor the heart. So it's very important to know all these correlations. So in some conditions that are not, for example, strictly the one that we look at, we have this with this correlation. So if we look, for example, genes that can affect cardiomyopathy, so nothing to do with what we are looking at. We have a lot of different genes, and each variant, each gene can cause a much different risk in terms of cardiomyopathy. So actually it's not just, it's not enough to say, oh, you have a cardiomyopathy and it's genetic. The type of the gene change that you have can give you a risk for your risk for having severe cardiac involvement. Now, so it's important, we understand that it's important, we need to have genotype-phenotype correlations for diagnosis and for prognosis. Sometimes, however, despite the fact that we have a gene A with a variant, and this is the phenotype that you have. I mean, imagine that these curves give you an idea of the progression of the disease, of your ability to walk or to do certain activities. So that's gene A, variant A, phenotype A in blue. And then you have maybe the same gene that can cause you a phenotype that is a little bit milder. You are actually more able to do certain things, right? But then you have another gene, gene 2, nothing to do with the first gene. We have a different variant. And actually, that gene is very similar to gene 1, variant A, variant B. So unfortunately, sometimes different genes can cause very similar phenotypes. Now, okay, let's say that I find variant A and I know that this is affected, causes phenotype 1. It's easy to see the difference between phenotypes later on, but if I look at the early stage of the disease, in early life, sometimes it's very difficult. So it's tricky to say very early on, just looking at the patients, if it will evolve as a milder form or as a more severe form. So it's unfortunately still not sufficient sometimes just to identify the variant and have an idea about the course of the disease. Now, as I said, I would like maybe just to skip quickly about the other forms of congenital muscular dystrophies, but we do know that in other type of early onset conditions, the gene that you have can give you a different phenotype. So muscular dystrophies with a lot of different genes. And for example, alpha-dystroglycanopathy is a group of conditions where we have a lot of different genes all causing the same presentation with brain and muscle and eye involvement. And according to which genes you have, you could have different type of presentations. So for example, these are all genes that cause alpha-dystroglycan-related muscular dystrophies. And depending on which gene you have, you might have different severity. These are all severities of the presentation. But we also know that this is a spectrum, and other genes that cause this form of muscular dystrophy could cause a much milder form. Some patients only have high CK or just a little bit of myalgia, so really no weakness, but the gene is the same. In particular, I'm talking about, for example, gene FKRP. And for this specific gene, we know that some patients have a very early onset with a bit like similar to what children with dystrophinopathy present, but patients who have this very mild variant can present with the so-called limb-girdle presentation. And this can be quite clear in the majority of the patient of this difference. So if you have this variant, you're milder. If you have other variants, you are more severely affected. So again, you have a sort of a genotype-phenotype correlation. But there are exceptions, and also with this variant, we have patients who actually, despite having this mild variant, are very severe. And the other genes, for example, GMPPB, where you have, for example, again, alpha-dystroglycanopathy, but if I look at the genotype phenotype, so these are all the variants, for example, that we have identified in our center. You have some variants that are much milder, where the children are relatively well strong and completely normal muscle MRIs, so no involvement, no structural changes that you can see in a muscle MRI, while other mutations are much more severe. It's the same gene. So clearly, the variant that you have has an effect and causes different severities of the disease. Okay, so let's look at LAMA2. So we already know what is LAMA2, and clearly we're all here because we try to have a cure, which is not there yet. And we know that majority of patients has basically, complete absence of myrosin. Now, we also heard before from Regan this morning at the beginning that, however, there's a proportion of patients who have some partial presence of myrosin. So if you look at the biopsy, you can see that there is a little bit of expression of myrosin. And already some years ago, there has been some studies to see is there is a genotype-phenotype correlation, and is there a difference that is really quantifiable between people who have residual myrosin and those who don't have residual myrosin, and why is this there? Is the type of mutation that makes this difference? So from a clinical point of view, so first of all, let's see if clinically, what's the difference if you have or not have residual myrosin. And overall, we see that people who have a little bit of myrosin left, the phenotype is later onset, is less severe, but is also probably more variable. The prevalence of mild myrosin deficiency appears to be a little bit less common. However, I think it's probably underestimated. we consider the partial myrosin deficiency to be much less common. If you think about it, probably 3% of the totality of people with the myrosin with LAMA2 variant in the UK population. But I believe, as I said, that this is probably underrepresented because people with who have partial deficiency could mimic other conditions and therefore not be tested for LAMA2 gene. And in particular, now it's appearing that if we test, for example, generally for any genes that we could implicate with the milder adult onset muscular dystrophy, the variants in LAMA2 are appearing. And this is a study that was done on a cohort of patients with limb-girdle muscular dystrophies without looking at specific group of genes. And again, they found about 2% of patients with the LAMA2 variant. But as I said, I believe that it's probably an underestimate. So then, what's our knowledge about people with partial deficiency? There are clearly, first of all, we need to identify patient, and the knowledge on this patient needs to be published. And there are not that many publications on people with partial deficiency. So these are some of the reviews, and I try to look at the numbers. And there are quite a few smaller case reports. And now the recent longitudinal studies, for example, that Regan and her collaborators have published is very helpful because we also have some longitudinal data on people with partial deficiency. But again, still, these are relatively small numbers. And what we see overall, that, as I said, that the phenotype is very variable. So the presentation can really range from quite severe early onset, almost like congenital muscular dystrophy presentation, to a milder later onset limb-girdle-like presentation. And recently, the group of Giselle Bon in France also described this quite severely contractural phenotype, where it really mimics a condition called Emery-Dreifuss muscular dystrophy, which is quite different, but clinically the patients seem very similar. Overall, we know that muscle function is much better preserved and that respiratory and feeding difficulties are less common. So in these pictures, you can see the contractural presentation with the finger flexion contractures, the tightness in the elbows and the spinal rigidity. And then in the biopsy, you can still see a variable production of myrosin, not only on the muscle fibers, but also on the nerves. Involvement of the central nervous system is observed, and you can also have abnormalities of white matter even if there is a residual presence of myrosin, but this seems to be more common when it's earlier onset the condition. So the later the onset, it's less common to have problems with the white matter. And then what is very helpful is the MRI that seems to be quite peculiar, and interestingly, the changes that you see on MRI when you have partial deficiency is similar to what you see, for example, in patients with collagenopathy. And again, this might explain, for example, why some patients might not be diagnosed yet, because maybe they have a wrong diagnosis of another condition based on their feature. And interestingly, collagenopathy is a condition that very often presents with contractures, muscle wasting, progressive respiratory involvement. And with this MRI, I wouldn't be surprised if some people are labeled with another diagnosis and not LAMA2. Okay, so looking in a little bit more detail about motor function, for example, between complete and partial. Again, still with the idea that if you find partial deficiency, what can tell you about future progression of the condition? This is from the paper from 2010 that was from our center. So we can see that there is a big difference in terms of ability to walk between people with complete deficiency and partial deficiency, with a great majority of patients with the complete deficiency that were non-ambulant, while in the partial deficiency group, you will see that there are at least 3 children who were able to walk with support and 5 patients who were walking independently. And this is clearly significant. So ambulation is much better when you have a little bit of dystrophy left. And the respiratory function also was quite different. And again, you can note that if we look at in the first column is the people with absent myrosin, and this column, the second, is always the patients with residual myrosin. And you can see that children and young adults who had some residual myrosin really had much less need for ventilatory support compared to when there is complete deficiency. This is not nothing or all, clearly you still have variability, but it's much less frequent. So we tried to look at this a little bit more in detail, and we recently reviewed a larger cohort of patients that have attended our center from 1996. We looked into data for over 47 patients, and 6 of these were with partial deficiency. And the follow-up time was quite long. We had data for some children for over 22 years, but unfortunately, because we are a pediatric center, we had no data for adults, and clearly this is a bit of a shame, particularly for people with partial deficiency, because we would like to have data about long-term prognosis and long-term evolution of the condition. So if we look at the data for the patients where we had more regular assessments, and unfortunately we only had data for 4 patients with partial deficiency, it's quite obvious what we already evidenced, that there is much better preservation of abilities in walking, much less frequent problems with scoliosis, and much less problems with feeding difficulties. But it's not, again, black and white. This is a condition actually starts probably in utero, and so it was also interesting to look at what are the symptoms before the children are born. Could we actually give any idea of genotype-phenotype correlation before birth? So what is the birth history between the difference between complete and partial deficiency? And clearly, children who have partial deficiency have much more frequently uneventful delivery, and the frequency of problems before birth are much less common, where you can see quite a number of patients with complete deficiency had polydramnios, they had less fetal movements during pregnancy compared to healthy children, and very much more often had problems at birth with need for C-section because of lack of movement and the breech presentation of the children. But as you see, the weakness also in children with partial deficiency at the onset were quite similar. So you have axial weakness, limb weakness, hypotonia. It's just that there might be that this problem starts a little bit later and not at birth or in the first months of life. One of the most striking difference is the respiratory involvement, and we already seen before, but also in the first paper, but in this most recent review clearly shows a striking difference between the patients who have partial deficiency. You can see these lines reflect patients with partial deficiency, and the blue lines are patients with complete deficiency. And these are the changes over time of their spirometry, of the FVC that we just heard before about the ability to do the respiratory assessment. And you can see that the people with partial deficiency have the 100% is, let's say, the norm, and their abilities are quite good, between around 80%, and usually between 80% and 100 we would be happy with those values. But the great majority, all of the people with complete deficiency had values below 60% with rapid progression, with an estimated decline of 2-3% per year. Now, we also had some people, in particular one child in this cohort who was quite atypical, who presented who belonged to a family where all the other family members had complete deficiency and had typical features of complete deficiency with no ambulation, severe respiratory involvement. But this child here actually was ambulant and had no, for example, major scoliosis or contractural problems. But if you look at her respiratory function, the respiratory function was completely overlapping what you see in other people with complete deficiency. So again, the variability, and even within the same person having, you might have some of your abilities that are much more severely affected than others. So in this case, for example, her muscle strength was very good in the skeletal muscle, but the respiratory muscles were much more severely affected as in a child with complete deficiency. However, none of the patients in our cohort who had partial deficiency needed ventilator, again reflecting the milder presentation overall. I think one of the important differences also that between complete and partial deficiency is the severity of cardiac involvement. And I think one of the things that we have to keep in mind also is that we don't have that much data on adults with complete deficiency, and we hope that this is something that we can improve we can learn a little bit more looking at the data of adults. But it looks like that cardiac involvement is much more an issue in adult life, so we really would need to learn a little bit more about this. And people with partial deficiency who are much better investigated in adult life compared to complete deficiency seem to have quite a relevant, I mean, we don't even have a percentage yet, but this is something that we have to keep an eye, because there might be rhythm disturbances that could potentially be affecting, clearly life. So I think it's important that everybody who has a diagnosis of LAMA2-related muscular dystrophy should have regular cardiac, just for prevention, to make sure that we don't miss any rhythm problems. Okay, so we talked about the beginning about the fact about what is the genotype, your variant, your gene, and your phenotype. So what are here? What are causing? What is the cause of this variability in this specific condition? So is it just the presence or absence of LAMA2 that makes the variability? So you do have laminin, you are milder. You don't have it, you are weak. You're weaker. Or is the mutation where the mutation is? So this is your gene, and these are your exons. So is for example, according to where the mutation hits, that you have more or less severe presentation? So are there any domains in the protein that are more important? So if I affect the protein here compared to here, could be much more or less severe. So again, just give you quick concepts about what are the mutations that we have and what is the effect of different mutations. So if this is your DNA, and each triplet, so 3 letters in your DNA, produces one amino acid, and the amino acids together is your chain that makes your protein, you might have different type of mutations. So missense mutation is when you basically have one single letter changed, and the change in one letter can create a completely different amino acid. So if that's the normal DNA, normal amino acid chain, and your normal protein, if you have a missense variant, this amino acid here changes, and you have a protein. However, the protein might have a different function. It might lose your function or might gain a function. Very often, missense changes can give you an abnormal, toxic function to your protein. However, not all missense changes are damaging. We all have a lot of missense changes. So if I sequence LAMA2, I need to make sure that the missense variant that I have is really disease-causing, and it sometimes is really a bit like hunting for a needle in a haystack. So I need to understand if the variant that I have is really the disease-causing. Then they have other type of mutations. You might have deletions, duplications. So if this is your DNA, these are your blocks of genome we call exons, so the building blocks of your genes. And imagine that each of these exons creates a part of your protein. That in this case, we just represented as a sentence. So imagine each part of the sentence is made by one of the exons. So if I delete part of this, I might completely lose the sense of the protein and basically not have a functioning message. And this could be what we call frame loss, deletions, duplications. You can have a similar problem also when you have a so-called nonsense mutation, where you have a missense variant in the gene, and you have the missense, that single variant causes a stop. So you have an early block, an early stopping of the reading. And then what you have is that you have a non-functional, shorter missing protein. And basically you would have no protein at all. And there's a last type of variant where you have something missing or sometimes duplicated, but the rest, so you have only one word missing in your sentence. You have a protein, but it's a little bit less working. And these are in-frame duplications or deletion. Now, all of these mutations can cause something different in your protein, and if I list all the different mutations that I showed you, so you have the in-frame deletions, missense, loss of function, deletion, duplication, and nonsense. The idea is that you have the normal protein. These are severe variants that should cause complete absence, and these are neither. And because you have a little bit of protein left, but maybe not functioning well. But this is unfortunately not the case. You don't have this very strict, clear correlation. And if you look, for example, at all the mutations that we found in our cohort, we see that loss of function variants very often do cause severe early onset condition. And some Also the location of some of this, if the affects this domain of the protein, are probably more severe, but missense mutation, well, missense mutation in particular in this part are a little bit milder. But we do have also people who escape this rule, who might have missense mutations, have very severe, and patients with nonsense mutation who are very mild. So why is this? We don't know. And again, other papers that indicate about this correlation. So milder mutations may cause milder phenotype. Now, the last two slides is just to the fact that, unfortunately, sometimes the type of mutation and the location of the mutation is still not sufficient, and this is something that we're working on. And a few years ago, in 2004, this couple of sisters have been described, where one girl had a very mild presentation, and the sister had a very severe presentation, and one of our colleagues, Veronica Pini, with the support from QCMD, is working on understanding why this is the case. So both the patients have a very severe deletion, so they have an out-of-frame deletion in the potent with no myrosin left in the muscle of any of the two girls. So this is not partial or complete. They're both complete partial deficiency. But if you look at the course of the disease of these two girls, patient A is still ambulant at the age of 29, while her sister had only been able to stand bilateral support for a very short time, but has been wheelchair bound for basically since she was 7 years old. And she's now also has ventilation and the seizures. So clearly there's a massive difference in the course of the disease. And this is really much similar to, for example, what we saw in our patients. So what is the project is now to try to understand if there are any modified genes that can affect the expression of the phenotype. And we're trying to assess differential expression of other genes, not just LAMA2, because clearly they have the same variant. So is there any other genes that explains this difference that might be differently expressed in the two girls that can explain this variability? So in conclusion, what we did is just wanted to highlight that genotype-phenotype correlations are important, but we really have a lot of information missing to clarify this, to be able to give a very strong prognosis just looking at the gene and the change. Perhaps what we need to is to make sure that we have a diagnosis for every patient, and that we really deep phenotype, in particular also the partial population, so we really have a very good idea. In particular, we aim to have a cure that makes a person with a complete deficiency to partial, what that means so long term. It's really important that we have this correlation. And we also have to understand what are the other factors that can affect the variability. So it's very important, because in rare disease that all this information will be possible in one center, so that it's important all of us working in the background, we collaborate and we share information between each other. Thank you very much for this.